Watch that. Hey, good evening, everybody. My name is Dr. Nathan Thompson with the Exemplified Health Center, affiliate of the Wellness Way. Happy Tuesday. I'm going a day late just because of Memorial Day yesterday, so I wanted to still go live with you. Today, I'm going to go over with you something that I guarantee will be controversial. Yes, it will probably offend some people, but I'm an equal opportunity offender. So I'm going to talk to you today about some of the most popular weight loss drugs that are out there. They're getting a lot of attention. Doctors I see on social media are promoting them to no end, and I'm going to talk about them. So let's go over the physiology with these type 2 diabetes medications now promoted as weight loss medication, and let's talk about how they work. Let's talk about the side effects in regards to that, and I'm going to give you my opinion on why I think that this is a really, really bad idea. Even though you quote unquote lose weight, what's interesting is they only talk about weight loss. They don't necessarily talk about fat loss, which should be the most important thing. So let's go over part one. What about these new weight loss drugs? Part two, I'm going to talk about solutions that don't involve weight loss medications as well. So if you guys are joining us right now, make sure that you say hello. Make sure you also let us know where you are watching from as well. I always love to see where people are watching from. So make sure that you say hello to me. So if you guys are joining us right now and you don't follow us, please give us a like, please give us a follow, please give us a share on this video. If you don't already, please follow us on YouTube at Dr. Nathan Thompson, Rumble, Instagram, and on TikTok. Please follow, please follow us on those platforms. Because YouTube and Rumble is where we do a long format version like we're doing right now. A lot of short videos that we do on TikTok and on Instagram. Yes, I am controversial sometimes because I want to stimulate conversation, because no progress can be made unless there is some level of conversation. But I want you to start thinking differently when it comes to weight loss and some of these medications that are out there as well. And if you guys are watching right now from the Chicagoland area, please make sure you go to the top of the page. You want to work with our office. You want to work specifically with me. Please make sure you go to the top of the page, or you can visit our Linktree account in the description in our bio on Instagram. And our next inflammation talk is going to be on Tuesday, June 6th, which is a week from today at 6 o'clock p.m. This is an in-person event. If you're from the Chicagoland area, please make sure that you register for that, specifically if you want to work with us. This is the best way to understand where you need to start as far as being able to overcome weight loss resistance. Remember, weight loss resistance is a symptom. Everybody ties their health into their weight, meaning if I just lose weight, I'm going to be healthier. That's not necessarily true, but inflammation is tied to weight loss resistance, cancer, infertility, thyroid disease, arthritis, type 2 diabetes, autoimmune conditions, hormone imbalance. All of those are tied to inflammation. Everybody talks about inflammation, but very few people actually can know what it is, what the immune system is doing, and what you can do in order to get it under control. So please make sure that you register if you're from the Chicagoland area. Please register for that right now. And we also have a pretty awesome announcement. If you're watching on Instagram, if you are watching on YouTube, if you're watching on Facebook, and you live in the continental United States, but you don't live in the Chicagoland area, coming soon, we will be doing an inflammation webinar, which means you'll be able to watch it from the comfort of your own home. Excuse me. And that way, we are going to be opening up some spots for working with people remotely in the continental United States. And so we are getting that in the works right now as far as finishing that up, as far as that webinar and getting everything situated when it comes to that. So we are probably looking at mid to late June that we'll be doing our first inflammation webinar. That will be online. Some more information to come when it comes to that. And then also coming up on Thursday, if you're from the Chicagoland area, a lot of people ask me about breast thermography. Dr. Nate, do you recommend breast thermography? The answer is yes, because it's non-invasive and it will show differences in heat that are related to changes in physiology of the breast tissue before it even can show up on a mammogram. So I'm huge into thermography. Actually, even a step before thermography would be Dutch testing. And Dutch testing will show changes in hormone metabolism that can then cause injury to specific breast tissue that leads to the formation of cancer within the breast. So we're going to be doing with Illinois Thermography. We're going to be doing scans in our office Thursday, June 1st from 3 o'clock to 5 p.m. Just make sure that you pause this video if you're watching on replay, and you can call the number at 815-482-6224, and then you can schedule that at our office with Cindy, who is in charge of Illinois Thermography. So really, really awesome things that we have going on in our office. So guys, let's get into the meat and potatoes of these popular weight loss medications that I don't like. All right. I'll just let you know right now, I don't like it, but I'm going to explain to you why, and hopefully you come to the same conclusion as well once you start thinking about physiology. Okay. So I'll always go back to physiology. And if it doesn't make physiological sense, then I'm not going to be a fan of it. And it has to do with this. I want to ask you guys a question. Is your body stupid or smart? Okay. Because the way that you treat your quote unquote health condition will be determined on whether you think that the body is infinitely smart and wise and doesn't make mistakes, but rather is adapting to keep you alive, or if you think that the body is just a bunch of machines, that it just gets genetically weak, that everything is just passed down from your parents and it's just machine and it just messes up, then therefore, if that is how you view health and how you view your body, then you are going to go down a different path when it comes to even weight loss as well. You're going to look at what you can do in order to chemically trick the body into losing weight. But if you look at weight loss as something that I can't do because my body is weak or that genetically I have some of the issues, then you're going to tend towards doing the drug solution. But if you want to ask the question why, that maybe weight loss resistance is actually a symptom, then you're going to want to go in a different path. Let me ask you a question. Is the body smart or is the body stupid? So let's look at autoimmunity, for example. When autoimmunity, think about it again. Is the body smart or is it stupid? If the body is smart. Is the body really attacking itself? Or maybe it's cleaning up damaged cells? See, if you think the body is stupid, then you think that the immune system is just messing up and attacking itself. If you believe that the body is smart, maybe that it's actually attacking or trying to clean up tissue injury instead. And it begs the question, why is that tissue injury actually happening? Look at cardiovascular disease. Is the body randomly just making too much cholesterol in the liver, or is there a purpose of cholesterol? Does cholesterol have a value in repair? So if your cholesterol is going up and the body is smart, why is it producing more LDL? There has to be then a reason why there is in need of repair. Yes, there may be a consequence of developing cardiovascular disease, but that's how the body is healing and repairing. And so you have to go much deeper than that. How about when it comes to type 2 diabetes? Is the body just randomly losing blood sugar control? Or maybe when it comes to type 2 diabetes, excuse me, maybe it's protecting your cells from the oxidative effects of too much sugar. Isn't that amazing? Because if you didn't develop type 2 diabetes, you'd already be dead. Maybe that those cells, if you actually took in that much sugar over and over and over again, maybe that sugar, which can be considered glucose, a dirty, quick fuel, maybe that's going to create so much oxidative stress in the cell that the cell would then die prematurely. Maybe insulin resistance is the body trying to protect itself. By the way, when it comes to insulin resistance, there's only one organ that doesn't become insulin resistance. That's your nerve system, which is why when you talk about type 2 diabetes, the first organ that will be affected will actually be your nerve system, which is why you have things like diabetes brain. And number two, why you also have problems with diabetic neuropathies. So what's interesting is your nerve system doesn't require insulin in order to get sugar into the cell. So maybe all of these are the body being smart and trying to protect you with, yes, a long-term consequence of developing an injury, but maybe your body is saying, I will do this if it helps you to live longer. Just a little bit of a different perspective. See, how you view the body determines the methods you will use to treat it. Let me say that again. How you view the body determines the methods you use in order to treat it. So hopefully that makes a little bit of sense, because if you view the body as dumb, as a bunch of pieces of machine that just start to break down, then of course the first thing that you're going to do is you're going to try to chemically manipulate it, unless you say the body is smart, and maybe what I need to do instead is start looking deeper to try to figure out why it is adapting in this way. Let me know what your thoughts are in regards to that, because if you think that the body is dumb, then of course you're going to run towards these popular weight loss medications. So, excuse me. So, if you think about this, weight loss medications are not new. They've been around for a long period of time. And in fact, I think they started in the 1940s, 1950s. The first weight loss medications were actually amphetamines. Basically, what they did is they gave you a massive stress response, because when you are massively stressed, guess what? You lose your hunger. So they just gave you a lot of nervous energy, and that actually was considered an appetite suppressant. Okay. If you ever heard of fen, for example, which was a combination of two basically amphetamines, and they took it off the market because it was stimulating the nerve system to have a stress response in the adrenals so much that it was blowing people's hearts out. That's why they saw, oh, hey, look at this. We have an increased risk of having a heart attack when they were on this medication, trying to use this as an appetite suppressant. Then you had in the 1990s, you had orlistat, which basically blocked the absorption of fats in your diet. And that caused a whole heck of a lot of other problems as well, because if you aren't being able to digest your fats, it's going to cause a lot of issues with gastrointestinal systems, system issues, diarrhea, things like that. And then, excuse me, you also have type 2 diabetes medications. So you have medications that they use for people with type 2 diabetes. And they said, hey, you know what? When we were giving these drugs to people, they were losing weight, which is why even some doctors will give metformin when it comes to first steps of weight loss. But now they have some of these new medications for type 2 diabetes that they started using about 20 years ago or so. And now they're actually repurposing them for weight loss, to help people with weight loss. So you guys have to understand the things like Wegovy, Ozempic, those type of medications, Mounjaro, these were initially supposed to be type 2 diabetes medications that they're now being repurposed to be used for weight loss. And make sure that you follow this all the way to the end, because I'm going to guarantee you that they're going to repurpose it for another use when it comes to these medications. So these medications that are all the rave when it comes to weight loss, they're called GLP-1 agonists, okay? So what are they called? Ozempic, Wegovy, and Mounjaro. Now, Ozempic initially was used for type 2 diabetes. The main name of this drug is semaglutide. And initially, Ozempic is used for type 2 diabetes, but then they repurposed it and called it Wegovy for weight loss. And one of the reasons why they repurpose it for weight loss is they increase the dose of that medication. And then you have a newer one that's come out called Mounjaro, which actually combines a GLP-1 and a GIP medication. And they say, yeah, it gives kind of a double whammy type effect. But again, they're using this specifically for weight loss. And I think that they're not even approved by the FDA when it comes to weight loss. I think Mounjaro is still awaiting it, but doctors still have the liberty to use these medications off label, which is interesting. Okay. So how do these GLP-1 agonists, what they're called, how do they work? So GLP stands for, excuse me, glucagon-like peptide 1 receptor agonist. Okay. So you have insulin, then you also have, which lowers blood sugar, and then you have glucagon, which actually works to increase blood sugar. So these things, when you look at it, how they work is they enhance insulin secretion. So basically what they do is they increase the secretion of insulin from the pancreas, number one, from the beta cells, okay? Now, and then what they also do is they inhibit glucagon release from the alpha cells. So you have alpha beta cells. One releases insulin, the other one releases glucagon, okay? And so when they are inhibiting glucagon, they're basically inhibiting the increase in blood sugar, or things to stimulate an increase in blood sugar, or increase or try to mobilize blood sugars, which is actually what you need when your blood sugars start to go low. Now, additionally, what they also do is they slow gastric emptying. They increase satiety and they reduce your appetite. And I want you to think about this. If it is slowing down the emptying of your stomach, that means that your stomach stays stretched for a longer period of time. And yes, you're going to have an increase in satiety when your stomach is stressed. Interestingly enough, is that when some people are having an infection in their stomach and we see a giant gas bubble, like on an x-ray, for example, one of the things that they may say is, gosh, I'm just never hungry. Well, because if the stomach stays stretched, those stretch receptors will tell the brain that you are full. So basically, if you look at the mechanism of action of how these things work, is number one, they're going to increase insulin secretion. And then number two, they're going to delay gastric emptying. Okay. That's the two main reasons of how they work. Now, what are some of the side effects? Are there side effects? I don't even call them side effects. They're just effects. So this is a natural effect when you start to change physiology. So the effects of doing this is, yeah, you're going to have lower blood sugar because it's ramping up insulin. But as other effects of delayed gastric emptying, you're going to have things like nausea, vomiting, diarrhea, dizziness, tachycardia, infections, headaches, and dyspepsia may occur. Dyspepsia basically means like reflux. Okay. So acid reflux. Well, of course, that's going to happen if you're, excuse me, delaying gastric emptying. And the reason why is because it's going to sit there in the stomach and churn around a lot more. And you're going to have some issues with stomach acid production and it going back up into the esophagus and burning the esophagus. Okay. So yes, there are infections. Now, what are some of the other side effects that are associated with this? Well, with other interventions that cause a quick decrease in body weight, don't say body fat, I say body weight, like doing a gastric bypass, is the same as with these medications. Cases of acute cholecystitis linked to GLP-1 receptor agonist use in the United States. What does that mean? That means you have an inflamed gallbladder, and so it causes gallbladder issues, which a lot of times, when it comes to that rapid, excuse me, weight loss, that can be brought on by doing some very unnatural things by changing anatomy or adding drugs, can cause gallbladder issues. So they know that this takes place in the literature. So gallbladder issues. But here's what I find so interesting is that when you talk about delayed stomach emptying, they have a medical condition that is a problem, and that's called gastroparesis. So delayed stomach emptying is known as gastroparesis. And if you look at people who have delayed stomach emptying as a medical condition, here are the exact same symptoms: nausea, vomiting, bloating, belching, pain in your upper abdomen, heartburn, and poor appetite. So really, one of the side effects of these medications is inducing a medically induced medical condition. All right. It's an iatrogenically, which means physician-induced medical condition. This doesn't sound like something that I want to sign up for or that I'd be waiting in line for as well. Now, let's go back to Guyton and Hall's medical textbook of physiology, because when I quote textbooks of medical physiology, I say, how could you argue with the very book that you should have read when you are in medical school, osteopathic school, chiropractic school? We all use the same book because physiology is, in fact, just physiology. And in fact, this is the most recent edition of Guyton and Hall's medical textbook of physiology, which I think is the 17th edition of it. So here's what they talk about: gastrointestinal hormones. So gastrointestinal hormones is a mixture of several important gastrointestinal hormones: gastrin, secretin, cholecystokinin, which controls how much bile your gallbladder releases, glucagon-like peptide, GLP-1, and glucose-dependent insulinotropic peptide. All right, so GIP. This is with Mounjaro, okay? So they can cause moderate increases in insulin secretion. These hormones are released in the gastrointestinal tract after a person eats a meal. They may cause an anticipatory increase in blood insulin in preparation for the glucose and amino acids to be absorbed from the meal. So they actually will cause an insulin secretion as a preparatory to saying, hey, we're getting ready for an increase in sugar and amino acids that are going to require insulin. These gastrointestinal hormones generally act the same way as amino acids to increase the sensitivity of insulin response, to increase blood glucose, almost doubling the rate of insulin secretion as the blood glucose levels rises. Other hormones that can either directly increase insulin secretion, because remember this, now it's not just these hormones. Are there other hormones that affect insulin secretion? And the answer is yes. So other hormones that either directly increase insulin secretion or potentiate the glucose stimulus for insulin secretion include glucagon growth hormone. Now, here's what's interesting: cortisol, which is a stress hormone, and to a lesser extent, progesterone and estrogen. Interesting, huh? The importance of the stimulatory effects of these hormones is that prolonged secretion of any one of them in large quantities can occasionally lead to exhaustion of the beta cells of the islets and Langerhans and thereby increase the risk for the development of diabetes mellitus. So what they're actually saying is that if you do have high amounts of cortisol, aka having high amounts of stress, or if you have higher amounts of estrogens, think about when you take your estrogen or higher amounts of progesterone, aka birth control, or you're on estrogen replacement therapy. All of these things can affect your insulin levels, requires more work by your pancreas cells, by the specific beta cells of the pancreas, and can lead to fatigue of your pancreatic cells that are producing insulin. So isn't that interesting? Is that maybe your doctor is just focusing on these GLP-1 agonists, but they haven't looked at a complete picture of what's happening with your hormones. So look at this. Wait a second. You mean to tell me that stress, estrogen dominance, which really has to do with your liver's ability to be able to metabolize these, also some issues with, when it comes to the gastrointestinal system, and birth control, they can all play a part in insulin resistance and type 2 diabetes? The answer is yes, it can, but how many doctors are actually looking into it? So here's how these drugs work. Number one, they're going to increase insulin secretion. So remember, when you are eating specific foods, you're going to see a rise in blood sugar, but you're also going to see, depending on the type of foods that are coming down the pike, you're going to see an anticipatory response with certain hormones to raise insulin as the food starts to go into the blood, start to raise your blood sugar. So it's going to increase insulin secretion chemically, and it's going to slow your gastric emptying. Now, if you know anything about insulin resistance, then you're going to say, hey, doc, I see a big problem with this. So the problem that I see with this is that, number one, is that it's only going to make insulin resistance worse. So it's going to increase by increasing insulin, it's going to further cause receptor site deafness, meaning that you're going to require more and more insulin in order to drive the glucose into the cell, which is what these are doing. But the problem is that eventually it's going to lead to pancreatic fatigue, because you can't keep whipping your pancreas for long periods of time. There's only so much that it can do. So it's going to increase manipulation or insulin resistance. It's going to manipulate the gastrointestinal system, which is going to be changing, basically inducing what's known as gastroparesis. And number three, leading to pancreatic fatigue. So at some point, the question begs is, hey, maybe this could actually lead to a point, if you do it long enough, in which you're going to need to be on exogenous insulin. And so the end game is that it's leading to lifetime use, meaning if you do it and you lose weight, doctors say you need to be on it for the rest of your life, which if you don't, because it's made the insulin resistance worse by driving up insulin chemically And by manipulating it, then you're going to need to be on a dose in order to keep driving insulin up. And so that's why they say, hey, you're going to lose some weight, but then you're going to have to go on a maintenance dose, because if you don't, the number one thing that people will see is they'll see rebound weight gain, which begs the question, it's not really getting to the reason why you are having some problems losing weight in the first place. Now, I don't know, guys, if you can hear this or not. If you can hear this, please let me know if you can or if you're not. But this is a weight loss expert on TikTok. And he's talking about, and you can read the quotations. And basically, he is saying that, hey, once you lose weight using these weight loss medications, just like cholesterol and just like blood pressure, you need to be on them for the rest of your life. Here's what's interesting is that we've actually helped people get off of blood pressure medication. We've helped people be able to get off of cholesterol medication. And somehow this doctor thinks that it's not, there's no way possible for you to be able to do that. Isn't that amazing? I mean, the medical profession says that there's no way that you can be able to get off of blood pressure medications or cholesterol medications. And they also say there's no way that you can be able to lose weight on your own. And you're going to need to be on these specific medications for the rest of your life. That's called job security. Bad information, bad advice leads to job security from this medical profession. Well, guess what? We want to actually get to the cause, a reason why this is happening. And you know what? We don't want you to be a patient here for the rest of your life, because if we can empower you and we can teach you how to take care of yourself, isn't that the essence of what a doctor's supposed to do? And not just say, hey, come to me after 3 months, I'll up your prescription. That's called being a drug pusher. And that's not something that belongs here in our healthcare system. Straight from the horse's mouth, a weight loss surgeon says that you need to be on these for the rest of your life. And so they are telling you that this is a lifetime medication. Dr. Nate, I'm fine taking this medication for the rest of your life. Huh, interesting. And I'll show you why it's going to be a bad idea. So the experts actually admit, because it manipulates insulin secretion, your pancreas won't be able to keep up with the increasing insulin resistance once you're off of the medications, which is why they say that you're going to need to be on it for the rest of your life. And so what they're doing, if you have a problem with insulin resistance, your cells can't hear insulin, pancreas can't keep up, they force and they manipulate in order the pancreas to make even more insulin. You're going to see the weight that starts to come down, but they're going to still force that insulin to get secreted from the pancreas. And eventually, I'm going to guarantee you the pancreas is not going to be able to keep up, and you're going to run into a whole heck of a lot of other problems down the road. Are you sure about that, Dr. Nate? Well, I can tell you my best guess, because the longest that it's been studied for is, I think, 62 weeks. So when a doctor says the science is settled, the science is clear, remember, they're pushing a lot of medications without any kind of long-term studies whatsoever. And these medications are actually one of them. So where do I sign up? So look at this. When you say a lifetime of medications, here is what Wegovy, here is what it costs. Okay. So let's look at this. This comes from the actual website. Wegovy has a list price of $1,350 for 2.4 milligrams. Let me say that again. It has a list price of $1,350 for 2.4 milligrams of this medication. That's if you don't have insurance. So why do you think the pharmaceutical companies are lobbying so hard to get this covered by insurance? And in fact, I read somewhere earlier today that it will cost, if it's approved by Medicare, it will cost the Medicare system $13 billion in payouts. No wonder they want this drug to be approved by insurance so much, because they want the $13 billion cash cow. So just remember this. So $1,350, 2.4 milligrams, that's what it costs. Okay. Now I want you to look at this. Is you can see that the different dosing of how you take Wegovy. So you look at this 0.25 milligrams on your first month, month 2, 0.5, month 3, you go up to 1 milligram each week. And then you look at 1.7 on month 4, and then month 5 and beyond is a 2.4 milligram each week full dose. So technically, that is going to be costing $1,350 times 4 per month. So you see what an utter cash cow this is becoming. And it's no wonder why so many doctors are pushing for this. It is absolutely insane. Now, here's a couple of other side effects when it comes to cost. So, yes, we talked about, problems with insulin resistance, number one. We talked about how it changes the gastrointestinal system. Number 3, we talked about costs. But here's some of the things that people ask me is they say, hey, Dr. Nate, what do you think about this Ozempic face? And basically, Ozempic face is when you do lose weight. You do lose weight. Didn't say muscle. You do lose weight. And what you see is you see sagging of the chin, and you see a very sunken in old look as a result of rapid weight loss. Didn't say fat loss, but rapid weight loss. Now it's so common that they call it Ozempic face. Now, here's what's interesting is this comes from a plastic surgeon. They said, well, if it causes Ozempic face, well, we also have some fixes for doing that too. You can do fillers, you can do skin tightening treatments, or you can do plastic surgery. So it is create the problem and then offer a solution with more surgery. Do you think your insurance is going to cover plastic surgery or fillers? I don't think that it's going to, but it just creates more and more problems. Here's another thing: weight loss or fat loss. So when I looked at the studies, when it came to weight loss, all they went over was about weight loss. And I didn't see any studies yet about fat loss. So weight loss would mean I'm losing fat. I'm also losing muscle mass, which is going to make insulin resistance even worse. But they just talk about weight loss. Oh, you can lose 15% of your body weight. Well, here's another way that you could lose 15% of your body weight. Cut off your leg, and that will cause a weight loss as well. Dr. Nate, that sounds pretty extreme. Exactly, which is why I think that these medications are actually extreme, because they're not measuring what truly matters, and it's fat loss, and it's not what your gravitational pull on the scale is. So I haven't seen a study when it comes to actual fat loss, because all they talk about is the amount of pounds that are lost or what your BMI is. By the way, if you look at the BMI, I'm considered obese, and I probably would qualify for this medication, even though body fat percentage runs at about 15%. So what are the long-term effects? So are there other long-term effects? This is another question that I have. What on earth are the long-term effects? Because when they say that it's safe and effective, this is what gets me. They say that it's safe and effective because they've been used as diabetes medications for the last 20 years. That I'm like, yeah, but does there amount of drug that they need to take, does it continue to go up? Do eventually, is it a zero-sum game where they're going to need to be on insulin injections? And the reason why is you just keep looking at blood sugar, blood sugar, blood sugar, blood sugar. You actually avoid and you completely ignore insulin levels, and you just keep looking at that blood sugar number. And at some point, the insulin resistance gets so terrible that you need to increase the medication. Finally, the pancreas can't get up, but yes, you can give them injectable insulin, which I see so many people that are doing. And by the way, we have actually gotten people down on units of insulin in weeks, which is why you have to get to the reason why it's happening in the first place. So this comes from the New England Journal of Medicine. This is the longest study that they've done to date. Once weekly semaglutide in adults with overweight or obesity. Okay, this is the longest study that they've done when it comes to weight loss, and the length of the trial was 68 weeks. Has it been for 2 years? Has it been for 6 years? Has it been for 10 years? Nope, it hasn't. And in fact, the people who are doing it right now, you are the guinea pigs, just like another procedure that they were pushing 2 or 3 years ago. And we're seeing how that works out as well. What about addiction? Because these are some of the things that people have asked me about. So they've actually have noticed that people who have been on this GLP-1 agonist have also noticed like, hey, I don't have as many cravings or for other things, or I was having addictions to other things like smoking or drinking. I just have developed just like kind of a distaste for food. So does it actually change the brain? The answer is yes. Okay. Now this comes from National Institute of Health, PubMed. This is from a 2020 study that they looked at central GLP-1 receptors, novel molecular targets for cocaine use disorder. So what they're saying is, well, yeah, we're seeing that it actually affects people who have addictions to other things as well. But I want you guys to understand this is people who are addicted to food, who are addicted to drugs, who are addicted to alcohol, typically have very, very low dopamine. And so they're always looking for that next dopamine hit, whether that's sugar, whether that's any kind of drugs or alcohol. They're looking for the next hit. And so these people do not produce as much dopamine, but it begs the question, which comes first, the chicken or the egg? So does the addiction cause low dopamine, or is the low dopamine, does it cause addiction? And again, it's going to come down to whether you think that the body is stupid or that whether you think that the body is smart. So this is the abstract that comes from that article that I just went over with you about cocaine use disorder. So they say this: recent preclinical evidence suggests that glucagon-like peptide receptor agonists could be repurposed to treat cocaine craving-induced relapse. Behavior, neurochemical, electrophysiological, molecular biology studies indicate that central GLP-1 receptor activation functionally modulates the mesolimbic reward system and decreases addiction-like phenotypes in rodents. So now it begs the question, is this going to become the next cash cow? And I'm going to make a prediction is that they're going to start using this to curb and control addiction. Okay. So the question is this: when you have doctors who are touting the benefits, who are saying how amazing this is, let me ask you a question. Who taught them? Who taught them? Did they actually open up Guyton and Hall's medical textbook of physiology? Or did the pharmaceutical company teach them at a weekend conference? That's my question. And if you're a medical doctor out there, please answer that question, because you didn't get it from, if you have been practicing longer than 5, 6, 7, 8 years, you haven't learned this in medical school. So who taught you? And if it's the pharmaceutical companies, then obviously they are going to tout the benefits and they're going to minimize the risk. But if you know physiology, then did you open up your physiological textbook that you should have learned when you were in school, but maybe you just memorize it so you could pass your boards and forget about it? But if you open it up again, then hopefully you come to the same conclusion I do, that this doesn't make sense. It's making the problem worse. And yes, if it's weight loss, yeah, it may be happening that, but at what cost and at what expense? So here's a question: does the behavior change the brain, or does the brain change the behavior? That's the question. So does the behavior change the brain, or does the brain change the behavior? What comes first, the chicken or the egg? And I lean towards that the behavior changes the brain. Remember, when you look at the brain is a receptor for what's happening in other parts of the body. The brain is the antenna. The brain doesn't just get sick for no reason. When people have a sick brain, they also have a sick body. So here's my final thought, because I know that people are going to they're going to comment and saying, yeah, but it helped me. It helped me and it got me my life back, whatever. Well, congratulations. I'm happy for you. But let me ask you the question: at what cost is that going to, is the price that is going to be paid down the road? And people say, well, we need to have compassion for these people. We need to have compassion for those people who are suffering. But this is truly what compassion is. Compassion means it's an urgent rush to help, an urgent rush to help. But if it makes them worse in the long run, then it's not compassion. It's called enabling. And if you've ever seen people who have been enabled their whole life, you will see that their life doesn't end up very well. And in fact, what they do is, if you especially deal with people who are dealing with addiction, you will see that they think compassion is enabling. They'll say, hey, give me what I want right now. And in reality, down the road, it's making them much, much worse. So don't mistake compassion and for really what it is. And it is enabling a behavior that will not make you better and healthier long term. So hopefully, guys, this makes sense. So coming up June 6th, if you guys are watching right now, please go to the top of the page, or you can go to our link tree in our bio, and you can register if you're from the Chicagoland area. Register for our upcoming, which is in 1 week, Tuesday, June 6th, an in-person event at 6:00 p.m. We're going to talk about inflammation, how it is a spark that leads to every single disease that is out there. And so this is in person. If you're from the Chicagoland area, please get registered for that. Also, as a reminder, we're putting in the works a webinar for people who live in the continental United States. So make sure that you pay attention to that, because that'll be coming up towards the end of June. And we'll be doing our first webinar event and have an opportunity for people in the continental United States to be able to work with me remotely. So if you guys enjoyed this, you're going to enjoy part 2, because we're going to continue about how you can change your diet and how you can change the way that you work out and how you can change your stress levels, your microbiome, and how that actually getting healthier will help you to lose weight the right way, not by ramping up insulin or by chemically manipulating your gastrointestinal system. And I always will say this, that when you do it according to physiology and how the body was created, there's never, ever going to be any kind of side effects, and you're not going to have to worry about that. But when man says, my way is better, this is why every drug that has been pulled off the market was first approved for use. So just remember that. And I'll see you next week, next Monday. We'll talk about part 2, and we'll give you some solutions. So guys, be well, be blessed. And as always, remember,